Good morning and good evening. Welcome to the 106th ICC webinar. I'm Dr. Levi Cho. Today, Dr. Junior Tu and myself will moderate this webinar. Today, we are so happy to have Professor Rami Hallac to give us this amazing lecture. Professor Rami Hallac is a distinguished imaging scientist at the Children's Medical Center, Dallas, and an associate professor in the Department of Plastic Surgery at the UT Southwestern Medical Center. And his work primarily focuses on enhancing pediatric surgical outcome through the innovative technological applications. Professor Hallac is at the forefront of integrating 3D imaging, modeling, and printing into surgical practice, and he leveraged these advanced techniques to create patient-specific solutions, significantly improve the precision and effectiveness of surgical planning. Beyond surgical planning, Professor Hallac has made substantial contributions to the field of medical diagnostics by developing sophisticated machine learning algorithms. These algorithms have demonstrated capabilities that either meet or surpass the traditional diagnostic standards, offering more accurate and efficient method for identifying medical conditions. Professor Hallac's publications contribute consistently and highlight his innovative approach and commitment to integrating cutting-edge technology with medical science to achieve tangible improvement in patient outcome. Today, he will share with us the topic innovative edge artificial intelligence and large language models in craniofacial surgery. By the times we have three very important friends will be our panelists today. The first one is the Dr. Dex Pascasios from the Partners in Plastic Surgery, Davao City, Philippines. Hi, Dex. And our second panelist is the Professor Po Chen Huang from National Taiwan University. Hello, Po Chen. Our third one is Professor Jong Yok Liu from the Kyungpook National University from Korea. So can't wait to learn from Professor Rami Hallac. So Professor, please.
Thank you so much, Dr. Cho. Hello, everyone. Thanks for joining today's webinar. And thank you for inviting me. I'm excited to be here today to share some of our recent work on AI in craniofacial care. In this session, we will walk through some of core concepts and take a look at recent research that brings these AI technologies to life. We will begin with a quick overview what AI and large language models are and how they relate to craniofacial surgery. Then we will look at a few recent papers that highlight how these tools are already being used, from image analysis algorithms to conversational models like ChatGPT. AI is transforming patient care by enhancing every stage of the process, from diagnosis to surgical planning and post-op monitoring. Machine learning models can analyze complex data like imaging scans and patient records and detect patterns or issues that might be missed by the human eye. In practice, we've already seen AI imaging interpret radiological images, help plan highly precise 3D surgeries, and even assist in the operating room through robotic tools. So AI brings a data-driven approach, helping us turn experience and intuition into measurable and actionable insights. Before we go any further, let's quickly clarify a few key terms. Artificial intelligence, or AI, is a broad term. It refers to computers doing things like usually require human intelligence, like recognizing images, understanding speech, or making decisions. Within AI, there's machine learning. These are algorithms that learn from data instead of following fixed rules, machine learning systems get better as they process more information, spotting patterns and making prediction. Then we have deep learning, which is a type of machine learning um, that uses multi-layered neural network, somewhat inspired by how the brain works. Deep learning is especially powerful for tasks like image analysis. On a different track, we have large language models. These are AI systems focused on language. They understand prompts and generate human-like responses by predicting what words comes next. ChatGPT is a good example. So while all of these fall under the umbrella of AI, they serve different purposes. There is no avoiding AI in healthcare today. Even in craniofacial care, there are already several devices that use AI to help with diagnoses and treatment. In just the past few years, the FDA has approved several AI tools for patient care. Some can measure baby's head shape from a photo, quickly trace cephalograms, or spot cavities and bone loss on X-rays. But as you can see, we still do not have tools that help diagnose conditions like cleft lip, cleft palate, or craniosynostosis. This is an important area for future progress. That said, many recent studies have developed deep learning models to detect cleft lip during pregnancy, diagnose craniosynostosis, and assess speech outcomes. I believe one of the challenges in developing AI for specialized fields like craniofacial care is the limited availability of high-quality training data. These models require large sets of identifiable patient images, but collecting and sharing such sensitive data is difficult due to privacy concerns and strict regulations in healthcare. In addition to FDA-approved tools, AI is now being built into technologies like augmented reality, or AR. If you haven't seen AR before, it's a way to add digital information like images or labels on top of what you see in the real world using phone or headset. A common example is a navigation app. You can hold your phone on the street and see through your camera, and the app shows arrows and directions right on top of that view. In short, AR blends real and virtual elements together, helping us interact with the real world in a new and more helpful way. In craniofacial surgery, we can use augmented reality to overlay patient-specific anatomy, like say a skull from a CT scan, directly onto the patient during surgery. You can visualize the 3D skull model and bone cuts or implant positions overlaid on the actual surgical field. All of this possible through AI. At our imaging center, we have just started using augmented reality in the operating room, and we've already done our first few cases with it. We're excited to keep using it and gather more data so we can understand how much it helps with accuracy and patient outcome. Now that we have seen how AI is being applied across the surgical workflow, I'd like to share some of our own work in this field. One project we've been working on uses deep learning to measure how symmetric lips are after cleft lip surgery. We recently published this work at the IEEE Face and Gesture Recognition Conference. After repairing a cleft lip, one of our key goals is achieving good symmetry between two sides of the lip. This isn't just about appearance. Asymmetry can affect oral competence, sometimes speech articulation, and certainly a patient's self-esteem and psychological well-being as they grow. We have done some earlier work on asymmetry where we used 4D imaging to capture dynamic movement and assess post-operative symmetry over time. This allowed us to measure subtle differences in lip movement and coordination, offering insights beyond what static photos or visual assessments could provide. These studies gave us the foundation for understanding facial functions and set the stage for applying AI to automate and scale this kind of analysis. 4D imaging is a newer modality that can provide great imaging data with high accuracy. However, it comes with challenges. It's expensive, technically complex, and not widely accessible in most clinical settings. On the other hand, 2D imaging is far more accessible. It's cheaper, easy to capture, and already widely used in clinical and research. This makes it ideal starting point for applying AI to automate and scale facial analysis. Even when we look at the FDA cleared AI tools so far, one thing is obvious. Most of them are built to work with 2D images. Why is that? Because 2D data, like X-ray or regular photos, is easier to collect, faster to process, and fits smoothly into the way clinics already work. It's been the easiest way for companies to get these tools into real clinical use. Even though research is pushing towards 3D and more complex imaging, most of what's clear today comes from 2D application. That's where the field has found its advantage so far. So in our lab, we tried to train and use AI models to analyze images. We started testing AI based on landmarking models of healthy control. And it's performed very well, giving us reliable points for further symmetry analysis. This shows real potential for automating and standardizing assessment for patients with cleft lip and palate. As you can see here, this approach worked very well for individuals without facial asymmetry. Typically, we use computer tools called facial landmark detectors to map key points on the face. We wanted to expand the use of these AI models to landmark images of patients with cleft lip and palate. But these models that worked well on controlled subjects struggle with patients who had cleft repairs. That's because most models are trained on faces without clefts, so they often smooth over or miss important features, precisely the one we need to evaluate surgical outcomes accurately. And when the lip is significantly affected, such as after cleft repair, automated landmarking tools can struggle to place points accurately, especially around scarred areas. This is important because inaccurate landmarks can affect how we evaluate speech functions and make decisions about these treatments. To solve this problem, we developed a new approach called CLP transformation, designed specifically to improve landmark detections in patients with cleft lip and palate. To build any reliable AI model, especially in healthcare, high-quality data is essential. In our case, that means images. The model learns by identifying pattern across thousands of examples, so the quality and variety of the image directly affects how well the system performs. Without enough relevant training data, even the most sophisticated algorithm will fail to generalize in real-world settings. But using real patient imaging brings us a privacy challenge. Medical images are considered sensitive data, especially when faces are involved. Even when we try to remove identifying information, AI models can sometimes remember what they saw during the training and accidentally recreate parts of the original image. That's why we looked for ways to train our models without relying on real patient images. So we generated synthetic data that represent accurate features of cleft lip. This slide shows how we generate synthetic training data to overcome the challenges of limited access to cleft patient images. Image A on the left is an original face from the public Helen dataset. You can see in B, C, and D are transformed versions of the same image, where we've applied controlled changes to simulate key features of cleft lip and palate, such as repaired unilateral clefts, bilateral clefts, and nose asymmetry post-surgery. Below each synthetic image, we show real examples of patients with similar conditions for comparison. The resemblance highlight how well these simulated images capture the clinical characteristics we care about. This approach allowed us to build and train models specifically for cleft analysis, without needing to rely on sensitive patient photos, while still preserving the anatomical realism required for meaningful landmarking. Next, we use these modified images to train a deep learning model called Mobile Net V2, which is known for its efficiency and accuracy in image-related tasks. By exposing the model to realistic cleft-like variations during training, we helped it to learn to recognize and adapt to the unique facial features often seen in patients with repaired cleft lip and palate. When we tested the models on real CLP patient images, the results were promising. We saw 13.7% reduction in landmark detection error compared to traditional methods. That's a significant improvement, especially in clinical settings where precision matters. With more accurate and automatic tracking of lips and surrounding areas, we can monitor post-surgical outcomes and speech development more efficiently. This approach also has practical benefits. It can speed up evaluation and make the process less tedious. This way, we don't only analyze static images, but also videos to help us assess how the lip moves during speech and also correlate the articulation with speech outcome. Because the model is lightweight, it can even run on mobile devices, making it easier to use during routine clinical visits. Looking ahead, we hope to expand this work by using more advanced techniques like feature-level adaptation and generating even more realistic representation of surgical outcomes using AI. But so far, in our previous study, we focused on improving how we detect facial landmarks. But accurate landmarks are just the first step. This study aimed to develop and test a deep learning system to assess lip symmetry entirely in patients with cleft lip, not just through landmarks and distances. We saw a chance for AI to do more. Instead of relying just on landmarks, we developed a deep learning model that looks at the entire lip image and gives an overall symmetry score. This approach helps us tackle two big issues. One, the subjectivity of human judgment, and second, the time it takes to do manual measurements. We used convolutional neural network, or CNN, that worked directly on 2D photos. It looked at the lip texture and shape without needing manual markings. Our goal was to give clinicians a practical, easy-to-use tool that fits the way symmetry is judged in real-world clinical care. In order to do so, we need a lot of data to train the AI model. Ideally, we train it on thousands of cleft patients' photos labeled by symmetry. But again, such data does not exist, and using real patient images raises privacy and concerns. Even if we remove names and blur faces, AI models can sometimes still remember parts of the image they were trained on. In some cases, it is possible for the model to accidentally create images or reveal features that look like the real patients. This is called model inversion attack, and it means someone could use the AI model to guess what the subject in the training data looked like. You can see here how the authors of this paper were able to regenerate the image on the left and how it resembles the features of the original image on the right. That's why it's so important to protect the data, limit access, and use methods that reduce the risk of this happening when we build AI tools for healthcare. So we got creative. We used public videos of people without cleft lips, like clips of people speaking, to build synthetic training data. We created two types of lip image pairs. Aligned pairs, where both sides of the face come from the same frame and show natural symmetry, and misaligned pairs, where we combined the right side of the lip from one frame with the left side from a different frame of the same person. This misalignment, like mixing talking and resting frames, gave us examples that mimicked asymmetry. We used these synthetic pairs because we did not have enough cleft patient data, and using real patient images raised privacy concerns. By training the model on these examples, we taught it to recognize patterns of symmetry by comparing the left and right side of the lip. It learned to spot even small differences, which is crucial because cleft repairs often leave subtle or clear asymmetries. We used the Siamese convolutional neural network, two identical branches sharing the same design. One branch looked at the left side of the lip, and the other one looked at the right side. Each branch created a feature vector in numerical symmetry of that side's key traits. Symmetric lips produced similar vectors. Asymmetric lips produced bigger differences. We trained the system using contrastive learning, teaching it to output small distances for symmetric pairs and large ones for asymmetric pairs. In other words, instead of labeling the lips as symmetric or not, the AI gave us a continuous scoring show how symmetric they were. This made the model work like a symmetry detector, assigning an objective score based on how similar the two sides appear. To compare the AI models with human judgment, a panel of experts evaluated the patient images. This 5-point scale rates symmetry from very symmetric, which is 1, to highly symmetric, which is 5, based on key clinical features like the lip contour, scar lines, and the philtrum alignment. This allowed us to directly compare AI predictions to human expert ratings. When we then tested the system on 395 real images of patients with repaired cleft lip and palate, plus control images from public datasets. The results were promising. During training, the model became very good at spotting symmetry, reaching overall accuracy of 98%. We then tested it on clinical data, and it performed very well as well, with about 88% accuracy. We looked at how the AI's asymmetry score matched expert rating. We saw a Pearson's correlation of 0.34, which is significantly better than prior studies. We also noticed that even expert agreement was only fair, underlying how subjective these assessments can be. As you can see, experts only showed fair agreement. This shows the potential of AI to provide a more consistent, objective tool for assessing lip symmetry after cleft repair. Our deep learning system offers an objective, easy-to-use tool that gives expert-level symmetry scores using just a 2D regular photo. No need for landmarks or special 3D equipment. But this is just the start. We are now working on AI models that can also assess speech and articulation. By bringing symmetry and speech together, it can provide a more complete picture of each patient's outcome, not just static lip symmetry, but also on speech and function. There are several limitations to this study. First, we worked with front-facing images and public datasets. Looking ahead, we want to improve the realism of our synthetic images using newer tools like diffusion models and add more clinical photos. So far, we've been training our AI models using videos of healthy individuals, not patients with cleft lip. While this helped us avoid privacy issues, it means the model hasn't been exposed to enough cleft-specific variations during training. To address this issue, we are now developing new AI tools that can generate realistic synthetic images of patients with cleft lip, like the examples you see here. These are not images of real patients, but images generated by AI. By giving the computer a written prompt, for example, a baby's face with an unrepaired unilateral cleft lip, or a baby's face with repaired unilateral cleft lip, we can create highly detailed, realistic images. As we keep developing this tool, we will be able to train future models on much better data. and more relevant data, helping us build AI tools that are even more realistic, accurate, effective, and useful for cleft care. One of the most exciting parts of this work is how it opens the door to data sharing between institutions without risking patient privacy, especially since our field relies on identifiable images. This means hospitals and research centers can work together, compare results, and even pool knowledge. In another study, we moved beyond image analysis and explored how large language models, or LLM, like ChatGPT, can assist with clinical communication. We focused on how these models can help answer patient questions and deliver medical information in real time. Large language models like ChatGPT have emerged onto the scene in the past couple of years, including in medicine and other specialties. These models are essentially knowledge engines trained on enormous amount of data, of texts, including medical literature. So you can ask a complex questions like, how is cleft lip repair performed? And you can get detailed answer within seconds. This capability makes large language models promising for on-demand knowledge and patient education. For instance, a patient whose child is scheduled for surgery might ask ChatGPT to explain the procedure in plain language, and it will produce a fairly understandable explanation. It all starts with an input, which is simply the question or prompt from the user. This might be something like, when should my child have cleft lip surgery? That input is sent to the large language model, which is a type of AI trained on massive amount of language data. It doesn't search the web or pull from a single database. Instead, it analyzes the structure and meaning of the question and generates a response based on the pattern it has learned. Finally, the model produces generated text that is clear and relevant to the user's question. This process happens in seconds and allows patients and caregivers to get understandable information on demand. Why this is helpful? First, families navigating conditions like cleft lip and palate often face a steep learning curve. This anatomy is complex. The treatment spans years, and the care team includes many different specialists. It is easy for patients and caregivers to feel overwhelmed or unsure about what to expect. Large language models can help them provide clear explanations about feeding after surgery, the timing of the palate repair, or how speech therapy fits into the plan. Second, traditional resources like websites or pamphlets are often hard to follow or scattered across multiple resources. Large language models can pull together trusted information from across disciplines, surgery, speech, orthodontics, and deliver it in one place, tailored to the patient's questions. And some tools even support multiple languages, helping families access information in their native language. Finally, large language models reduce the burden on clinical teams by reinforcing information outside of clinical visits. Families can revisit answers, ask follow-up questions, and build confidence in their understanding, all without needing to wait for their next appointment. So in our study, we decided to test the large language models in answering clinical questions. We designed a set of common patient and parent questions related to cleft lip conditions. We focused on 10 of the most commonly asked questions, which we selected from the American Society of Plastic Surgeons Patients Information Material. We entered these questions into ChatGPT and collected its responses. Our goal was to understand where the model performs well and where it falls short, and how it might one day support or even enhance clinical communication and decision-making. We also had expert clinicians review the responses for accuracy, completeness, and relevance. Experts rated the responses on several key points. First, content quality. Was the medical information accurate and meaningful? Clarity. Was the explanation easy to understand for patients? Relevance. Did it directly address the questions asked? Trustworthiness. How reliable was the information? The ratings process was critical because it helped us see where the model performs well and where it still needs improvement before it can be safely or effectively used in clinical settings. ChatGPT scored on average 2.9 out of 4, with high ratings for content, quality, and clarity, but slightly lower trust scores due to missing citations. The readability was at 10th grade level, making it a little challenging for some patients. Overall, the model provided generally safe, relevant information, but still needs oversight before clinical use. However, there are some limitations. The models do not guarantee accuracy. They sometimes sound confident, but they can be wrong, or they might omit important information. Sometimes large language models' response often lack citations to back up their statements. This makes it hard to verify the information unless you already know the topic. So while large language models are powerful tools for communication and information, in a medical context, we have to use them carefully, ideally verifying their responses and treating them as an adjunct, not a sole source of truth. Because of these challenges, we saw the need to develop something more robust. That's why we built Clara, a system designed specifically for cleft, combining already developed language models with a verified knowledge base. The knowledge base can come from our department website or information that we provide rather than using the internet. This means every response Clara gives is grounded in trustworthy medical resource, reducing the risk of hallucination or unverified information. This is how it works. It all starts with a user question. A parent or caregiver might ask, for example, when should my child have their first surgery? Instead of the system trying to answer purely from online sources, it first performs a semantic search. This means it looks through a knowledge base, a carefully collected set of documents reviewed by craniofacial specialists, to find the most relevant information. Once the right documents are retrieved, they are sent along with the original question to the large language model. The model reads both the question and the selected document together, helping it focus specifically on validated information. Finally, the system generates a response that is personalized and easy to understand. This approach keeps answers accurate, clinically sound, and easy for families to understand. This is how Clara webpage looks like. In this demo, we are showing how the application works. The first question is, when will my child need palate surgery after the lip repair? The app gives a specific response based on our hospital documents. It says palate surgery usually happens around 4 to 6 months old. That matches the care plan at our hospital. Next, we ask, what feeding challenges might we face before surgery? The app remembers that you're still talking about the same child and the response in context. It explains how babies with cleft palate often have trouble feeding, and that special bottles are often needed to help. Again, this is pulled directly from the hospital's material. It's not making things up. Then the user can ask, can you recommend a diet after surgery? And here's the important part. The app doesn't try to guess. It simply says this information is not mentioned in the document. That's exactly what we want healthcare tools to be. If the information isn't available or verified, the system will say so. The second demo shows how the app gives parent helpful answers based on the hospital guidelines and does so in a way that's easy to understand. When a parent asks who to contact after their appointment, the app points them directly to the nursing team, not just a general help message, but an actual clinical contact path, which makes a big difference when families need a quick reference. It also explained clinical concepts clearly. For example, when asked about NAM, a treatment that many parents have never heard of, the app explains what is it and why it matters, using plain language. And as you can see, it can even respond in different language. This helps families who might not be fluent in English, but still need accurate information to support their child's care. We tested Clara extensively with a wide range of real-world questions, covering topics like surgery, timelines, feeding techniques, and long-term speech outcomes. Across the board, Clara delivered accurate answers. During testing, we found no hallucination, no irrelevant information, and no unverified content. This showed that the RAG framework, by grounding the chatbot's answer in vetted knowledge, really helped maintaining reliability and trust. Clara also supports multiple language, making it accessible for families who speak languages other than English. In short, Clara has proven to be safe, accurate, and patient-friendly tool for cleft care education. AI is transforming how we understand and improve patient care, making assessment faster, more consistent, or more accessible. This is just the beginning of building smarter tools that truly support our patient. This work couldn't have been possible without the incredible scientists, physicians, and dedicated medical students and PhD students on our team. It was a true collaborative effort developed in collaboration with Carnegie Mellon and UT Dallas. I'm grateful for everyone's contribution to this work, and I thank you all very much.
Thank you so much, Professor Hallac, for this amazing talk. You really opened up our eyes on how AI can help us in the future. So without further ado, I'd like to invite our panelists for some panel discussion. And the first person I'd like to invite is Dr. Dax. Dax?
Hi, good evening, everyone, or good morning, wherever you may be. Thank you, Dr. Hallac, for that work and excellent work. Really good talk. And I just have a few questions. Number one, how is Clara, right? Is Clara only accessible to patients from UT Southwestern, or can it be accessible also to the different patients, even if it's not from your center?
So we've developed Clara, but we haven't put it on the internet yet or the web. So it can be deployed and anybody can access it, and it will only answer questions based on what we on the database or knowledge base that we provide. So yes, it can be accessible to everyone, but so far it is being deployed locally, so it's not on the internet yet.
Oh yeah, because technically the reason why I was asking is because my qualms with this one is that how would Clara actually account for the differences in the different protocols between different centers? Because this can be a double-edged sword where the Clara would actually answer like we're going to operate on the baby on 3 months, but a different center might operate the baby at a different time, and this might affect the doctor-patient trust relationship.
Yes,
So
that's
if ever it would be available on like for everyone, would there be an option where the different centers would be able to put or input their protocol so that it can be specific to those specific patients?
yes, that's correct. So the idea is that in the future we probably can deploy something like Clara on our local webpage, like let's say UT Southwestern or Children's Hospital. But then everybody can put their knowledge base in it and deploy it on their own webpage. So everybody would, like when the patient goes to the webpage, instead of trying to search through the webpage to see what information they need, they can ask the chatbot, and it will answer the questions that you guys have on your own webpages.
Okay. Second is going back to the bot or AI where you take the pictures and then it can actually detect future problems of the patients. I was thinking if there are what the future is on the higher models, like the more practical side of it. Like, would it be possible later on where post-operatively we can take a picture of the palate post-op and then the AI can actually detect whether there would be a higher chance of getting VPI in the future? Would it be possible with that AI?
Maybe. We haven't tested that yet. So we've been working on cleft lip only. But maybe it might be a good idea actually to try to see if this works Most likely, we will probably need some radiological data, like maybe X-rays, to look at VPI. But I think AI can be possible in detecting that, but not from 2D photographs.
Yeah. Okay. On that note, on the data, I was going to ask what can high volume centers do to actually help train the current models? Like, have you tapped our friends from the international foundations like Smile Train or OpSmile so that we can have like higher volume and then we can actually incorporate the data from the different centers?
Unfortunately, we haven't. But that's why we are trying to move towards synthetic data, where we try not to use like real patient data for privacy. So what we are trying to do now, as I show in the PowerPoint, trying to combine large language models with CNN models to generate patient realistic images. So you can ask questions or say, I want an image of a baby with cleft lip, and then it will generate that image for you, which is similar to realistic image, but it is AI generated. This way, it's easier for us to to generate more data and also prevent, secure patient privacy.
I guess I'll leave the other questions to the other panelists. Thank you so much again, Professor Rami.
Yeah, that was great. Thank you.
Thank you, Dr. Dax. Next, I'd like to invite Dr. Huang.
Yeah, Professor Hallac, this is wonderful talk. I have about two questions. Maybe the 2D image transformation to create more data to training the AI is very fantastic. And this is consider about the privacy. Do you try to start from catch the 3D image, like from the 3D MD to take about the more 3D image to copy the list concept to do a more a lot about the database to training the AI? Do you have this kind of the work is ongoing?
We are not working with 3D images for AI. If that's what you're asking. So in order to train the AI with 3D models, we need like very powerful computers. We still don't have those at our center yet. And also we don't have a lot of data from 3D. So the idea was, to train the models on 2D images. But in the future, yes, once we have more data, 3D images can be more accurate because it doesn't only it will also look at the depth. One issue that might be arise, especially if we're looking at scarring or like scars from the surgery, usually 3D images don't have high resolution to look at the scar or the texture. So this can be an issue. But again, as technology progress, 3D images will be very helpful to train AI.
Yeah. So your second part about your speech from the use the chat GPT to make more friendly for the family to ask some question from the about collect the education care and the post-operative care. It is very useful tool. Do you have some this is my idea. Maybe we can to let my family to upload some baby's image to this kind of the uh, chat GPT, maybe to from this kind of the image, because different kind of the patient have the different cleft or the morphology, and give them more detailed information or some guide or some suggestion for the further treatment. Maybe this could be done to combine with the image and the large language system, maybe in the future.
Yeah, that'll be a great idea. One issue might be is again like patient privacy. So, but if the parents are willing to upload that, I think that will be a great idea. It will open doors for so much possibilities.
Now, do you think about the database from the large to upload to the Chat GPT? I'm really consider about there are a lot of about different team have the different opinion to treat. Yeah, so you will discuss or to organize some meeting to make the one opinion to upload to the chat GPT, or you will give more option to the patient or family to choose the different opinion from your expert in your center.
So you're asking if the parents can review the questions or the answers, or ask the questions so we can generate the answers for them.
My question is, there are different experts in your center.
Right.
Maybe they have the different kind of the opinion. So maybe you will to organize the meeting to confirm the one only the answer to upload to the chat GPT, or you will give the parents to the option to ask. Different kind of doctor will give different kind of opinion. This opportunity to make a patient's family to choose.
Yeah, yes. I mean, I think we can do that. So when we ask the parents the physician's opinion in our center, of course, everybody had different rating or or different assessment. So what we try to do is try to look at the consensus, but at the same time, it is difficult to know like what is the ground truth sometimes, right? So I mean, if you have a better if you have an idea that we can try, they'll be very helpful.
Thank you for your kind response. Thank you.
Thank you.
Thank you, Dr. Huang. And next, last but not least, I'd like to invite Dr. JY.
Hello, my name is Sung Ryu from Korea. I'm honored to participate as a panelist. And Dr. Hallac seems to have effectively summarized the evolution from early medical AI research to recent AI models. Early medical AI research primarily focused on image-based diagnostic assistance, largely because the most popular deep learning approach utilized convolutional neural network, CNNs. However, ChatGPT is based on a transformer model. GPT stands for Generative Pre-trained Transformer, and since the introduction of the transformer model, research on medical AI using CNNs has been losing popularity, I think. This shift occurred just a few years ago, and although transformer models were originally developed for language processing, they are now being applied in image-based research, such as with unit transformer. Consequently, future medical AI research is likely to see more studies leveraging these advanced models. And I have just two questions for you. First one is large language models like ChatGPT can be trained by professional healthcare providers, but they may also learn incorrect information. As a result, the outcomes may not align with what healthcare professional desire. And what is your opinion about this?
So yeah, I mean, they can learn something that the healthcare provider doesn't agree with. But what would be the idea is training it on an opinion that the craniofacial care thinks it's accurate, right? So we give it a knowledge base that the craniofacial team thinks this is the standard, like let's say in our center, and have the large language models, only be trained on that data.
Yes, because ChatGPT is only used until 1 years ago information.
Right.
So ChatGPT cannot use the recent research. So that's why I asked about the question.
Yeah. So we are not training the large language models again, but we're using RAG, which try to look at the knowledge base that we provide. So it doesn't go to the it doesn't give the answers directly from what it has been learned on. It gives the answers from the database or the knowledge base that we provide. So as long as we keep the knowledge base updated, it will keep answering relevant information, like
Okay,
up-to-date information.
thank you. Next question is for about research using the image photos. I think a limitation of the learning using image photo is that results can vary depending on race. This is because pixel values in photos differ based on race, especially in countries like Korea or Taiwan, which are composed of a single ethnic group. Research using image photos face the challenging of being difficult to apply the other countries. I assume the US has patients from various racial backgrounds, but how solutions were implemented to address this?
Yeah, exactly. That's why trying to generate synthetic data can be very useful, right? So you will not have imbalanced data anymore. So like, let's say if we were successful in developing the diffusion model, where we can generate synthetic data by just saying exactly the prompt we need, then we can ask it generate based on gender, based on race, based on ethnicity. So that way you can get not only like one set of data that will be unbalanced, but we can have, let's say, thousands of images from every, like, whatever you ask it to generate. So that will be like very balanced data, and it will not be biased towards one thing. So I'm very excited about like the idea of trying to use synthetic data. I'm not sure if it's going to work, but this is our, the next steps to see how good we can generate these synthetic data and how good the AI models will be trained on.
Thank you. Thank you for your answer.
Yeah, thank you, Doctor.
Thank you, Dr. JY. Next, now that we finish our panelist session, we will now move on to our Q&A session. And we have a few questions from our audience. The first one is from Dr. Huang. And Dr. Huang's question is that since your model is currently trained solely on synthetic generated images, do you believe that by incorporating real clinical photos, assuming that patient consent is obtained and privacy concerns are addressed, could you significantly improve its accuracy in detecting lip symmetry?
Yes, absolutely. So one thing we are trying to do in terms of that is use patient data, but with keeping privacy of the image content. So for example, what we're trying to do is take an image of a patient with cleft and then mask the area of the midface, like the mouth and the nose region where cleft asymmetry is affected. And the rest part of the image, the eyes and everything else, will be synthetically generated. So we keep the lip and the mouth area from a real patient, but then we mask, we synthetically generate the rest of the face. So that way we can use real data, but keeping the privacy. And I think this will help the model a lot because it looks at real data, not just synthetic data.
And also, aside from the privacy matters, do you think there are any other challenges that you might have to face when collecting real world data?
Yeah, I think the only problem would be is the number of images we have. So in order to use these data, we either have to have patient consent, but even not, usually the AI models require a lot of data. Like the system we trained it on with synthetic data, we used about 40,000 images. Having this much data from real world is very limited.
And our second question is from Dr. Lin. And the question is that since your team uses image-based data, have you ever, experienced kind of like motion artifact or image artifacts when you're not using synthetic data? And how do you deal with them?
Yeah, we always have motion artifact. So in our center, we have a studio. We try to get as good images as possible. If not, we retake them to make sure that they don't have motion artifact. One way would be possible in order to avoid that is using video, because you always can look at the video and select the frame without motion artifact. You can use those data per se. Other ways would be train the models on motion artifact and let the system figure out what artifacts is. But yeah, I mean, dealing with babies and images can be very difficult sometimes.
Okay, and I also have a question for you. Since, nowadays a lot of our patients go to ChatGPT first prior to, consulting physicians and whatnot. One of the problems that you also mentioned is the problem with noise and hallucinations. Is there any way that we can, recognize these hallucinations?
That will be very difficult to recognize them. But but ChatGPT and the large language models are getting much better with hallucinations. So the answers they're giving are more accurate. Then now some of them they provide citations where you can go to the web page and verify the information. But if you're not expert in the field, it is sometimes hard to spot hallucination. But that's why if you use the RAG system, where we provide it with only information that we would like it to answer, hallucination will not be an issue anymore because it will not be able to access the internet or say something that is not true.
But then that's the really interesting part about your model, because with Clara, you guys are able to kind of design the platform so that when they ask a question and it does not know the answer to, it will specifically say that. It will say
Yes,
that I do not know the answer of this information. However, with ChatGPT, they'll just make something up.
right.
So what is different from your model and ChatGPT's so that yours is able to, be able to say that, I don't have the information to these questions and whatnot?
Yeah, so again, we use the RAG model. It's a model that is a vector model that looks at the question and doesn't access the internet or the trained data. It only accesses the knowledge base or the documents that we provide. So so what happens is we wrote a program, right, that will only specify it to do that. Even so, if you download, like, let's say, ChatGPT 3 onto your computer, you can ask the questions without using internet. You can use it locally. So it doesn't need to know what has been trained on knowledge, because you only use ChatGPT just to understand the words and regenerate the answer. But the knowledge comes from the documents that we provide, not from what it learned on the internet.
Okay, thank you so much for these answers. So once again, thank you so much for your presentation today. I'd like to hand the mic over to PY for the conclusion.
Yeah, thank you, Rami, for your very comprehensive introduction of how the AI works in the field of craniofacial surgery. And I have my own question for you as well. So far, I already have acknowledgement to know mainly our AI based for the craniofacial surgery is working on the image. Is it possible to apply on the audio? Because for example, a patient with cleft received the parodonticity, and however, patient has no good quality of the speech, and how we could combine probably the nasopharyngeal scope, the image might be each dynamic one, and correlate the patient's resonance, the speech. So is it possible to know and to make a good prediction or the diagnosis to know how severity of the speech problem, and we could provide some kind of a treatment for those kind of possibility. Yeah, I know the audio so far is very challenging one. Yeah,
Mhm.
instead
Yeah.
of the image one, right? Yeah, so
Yes.
as you know, is it possible in the future? Mhm.
Yes, that's a great question. Yes, you can train the AI models on audio. Many centers are doing it. We've tried it as well. It works very well on the audio systems or the audio recordings that you have. The problem that has been the challenge that's been happening with audio systems is that it's not generalizable. So when you take it to the clinic and you start using it, the accuracy drops dramatically. So once you train it and validate it, it works very well. But once you take it to the clinic, it usually doesn't work as good as, like when you tested the models. There are many reasons for that. I'm not sure if there's one is more applicable or not, but mainly probably like, the quality of the audio recording or the sentences that you use or how fast or slow the patients speak. That's why you'll need a lot of data, to train the models. The more data you train it on, the more accurate it will be. But definitely, lots of centers are trying to work on that.
Yeah, thank you for your answer. Thank you, Rami. And before I make the conclusion of today's our webinar, I would like to invite our chief, Professor Clement Lin, to give us an introduction about at the end of this month, Chang will hold international cadaveric dissection course. So, Professor Lin, yeah, please.
So in this month, June 26 and 27, Chang will organize orthodontic surgery course. It's working on cadaver dissection and including the lectures. So the main theme is on the counterclockwise and clockwise rotation. So during this course, we would share with you some fundamental things about the osteotomies and also how to avoid the complications. And more important part is to use the endoscope to apply the nasopharyngoscopy to observe the pharyngeal airway changes during this movement. So with that maxillary and mandibular advancement, counterclockwise rotation, or the second day will be clockwise rotation. We can find out what's the proper modality or the proper design for orthodontic surgery to achieve a good relationship of jaw bones and also the pharyngeal airways. So for these informations, if you are interested, please scan the registration QR code. And also we provide the group registration discount for trainees and observers. So if you have any further questions, please feel free to contact me on WhatsApp. So thank you.
Thank you, Professor Lin, for this very important information, and all welcome for your participation in this great activity with us. I believe Professor Clement Lin organized a very wonderful the schedule and the program, and to give us a very advanced facility and the instrument. This could make it very real, and when we are practicing, like very similar to lab surgery too. All right. Finally, I will invite all our participants. Please turn on and your screen, and we need a group photo. Before I take the group photo, I have introduced Professor Hallac again. Professor Rami Hallac is the one I met 10 years ago when I was in Dallas M Center. And actually, he guided me to do a lot of research, especially in the image. That's why I came back to Chang to mainly focus on my research in my hometown. So I really appreciate his whole teaching and the guidance when I was in Dallas. So, okay, all my friends, please come back And wake up. Thank you. And our next webinar is 1 week later. And Professor Fadi Hussein will give the Professor Fadi Hussein from Egypt will give us a topic, the MARPI. Yeah, that is orthodontic relevance. The topic is a very good teacher, so amazing one. Welcome again. So I will count to 3, and please give me a big smile. Thank you very much. Okay, 1, 2, cheers. Thank you so much. And I have to say thank you again to Rami, because Professor Rami has been invited 3 years ago to ICC, and this is his second time to share his recent research to us. And congratulations to Professor Rami's achievement. And thank you for our 3 important panelists, Dex, Dr. Liu, and Professor Huang from National Taiwan University. And thank you, Professor Clemens' introduction about our cadaverous course. Good morning and good evening. See you next week. Have a good one. Bye-bye.
Y'all.
Thank you very much. 谢谢. Thank you, EK. Thank you, Natalie. And thank you, Professor Hangda. Thank you again. Thank you. 谢谢主任，谢谢辉哥。OK， 晚安。
Okay. Good
好，
night.
谢谢博成，谢谢，拜拜。
See you tomorrow.
See you tomorrow. Okay, we have to work. Bye bye.
Bye bye.
Bye bye.